So go ahead and put your phones up and let's get started on NSAIDs. So NSAIDs, yesterday we talked about salicylates, which are your aspirin, BC powder, your aspirin products, and then we talked about non-salicylates, which is Tylenol. Both of those, we said, well, I say both of them, which one of those had anti-inflammatory effects? The salicylate. Did the other one? No. NSAIDs, yay or nay? What do you think? Yes, they are non-steroidal anti-inflammatory drugs. So, a key component, so just like we talked about yesterday, a lot of this is going to be repeats from yesterday because we're still giving them all for the same reason, which is pain. So what are we assessing for pain? Where it is. How it is. Yes, all of those things, all of those descriptors we have to assess. So, again, it's the same whether you're given a salicylate, an opioid, a NSAID, whatever. That pain assessment is going to be a priority thing to see, what's going on with them. So, location and intensity are the basic components of an assessment, and it's important to remember that the sensation of pain is subjective. So, when I was talking to my freshman the other day, we were talking about assessing pain. And their question, it was a great question, what if your patient says it's a 10, but they're jumping around like a crazy person and they're, it's not affecting them and you know that it's not a 10. What do y'all think? It's not congruent, but what is, at the end of the day, pain is subjective. It's what your patient says it is. Which I know sounds crazy, but I can't look at Emily and say, Emily, you really don't look like you're hurting today. The same way that I can't look at Alexia and say, I really think you're depressed. Those are subjective feelings. So, the job as a nurse is to look for those congruencies. So you may document patient reports, pain 10 out of 10, noted, jumping on the trampoline with friends, whatever they're doing, and so that you can draw attention to that, but it's not our job to say she's not really hurting because pain is subjective. Because pain is subjective, effort is taken with standardized pain measurement tools to help the patient relay information needed. Give me 2 examples of those tools. It's very simple. What tools do we use to measure pain?
1 out of 10 scale.
1 out of 10 scale. You're not wrong, but I'm talking scale-wise. 1 out of 10, and what did you say? Oh, you said the same thing?
The faces.
The faces, the Long-Baker Faces scale. So y'all know this stuff already. All right, so again, all of these things we talked about yesterday. Their subjective description, location, intensity, severity, duration, factors that influence pain, quality of pain, patterns of coping, effects of previous therapy, and the nurse's observations of those behaviors, like we discussed, so that we can point out those congruencies or incongruencies. Sample questions. Y'all know all this stuff. Does the pain keep you up at night? Is it affecting your ability to walk to the mailbox? Is it just being, another one of the things my freshmen said the other day, they were like, so being a nurse means you're nosy. I'm like, pretty much. If you're getting all the information that you really should be getting, you're asking questions that are a little bit forward. All right, so populations, I like to ask y'all this stuff before I show it. People who are at risk for poor pain management or poor pain assessment, who do you think that would be? Who do you think is we may not get a real good picture of what their pain is like? Children? How come?
Because they don't really know what pain feels like.
Right, exactly, 100%. Right, so not only do they not really know how to describe it, they're dramatic. My Maddie that y'all watched the video, sometimes I have to tell her, like she was squalling the other day and she wasn't eating, but I was ignoring her because she squalls probably 2 hours out of every day. Sometimes it's because her crayon broke, and sometimes it's because, whatever, her hair's sticking up and she can't find her JoJo bow. Sometimes it's because her brother's aggravating, sometimes because we're out of yogurt. You know, so when she's bleeding, it's hard to determine, you know what I'm saying? Like when she says she's hurt, I mean, is she really hurt? So a lot of times parents are like, you're fine. On top of the fact that they don't even know how to communicate this or anything. What other population?
Older people.
Older people.
They
What?
think pain is part of aging, so they don't report it.
Yes, that's like I was telling y'all yesterday when somebody said, oh, it's not bad. It's just like a tube. But they no longer get their mail and they stop going golfing. You know, all of these things that interfere with their quality of life. What other populations? There's one other big one that I'm kind of
Asians, like cultural.
Cultural, yes. And we'll put those together. Culture, in addition to, well, we won't put this together. Culture is a very good one. Some cultures believe it is your duty to hold yourself together and to present a strong facade, and you shouldn't complain. And there's one other group that I'm thinking about specifically. Not so much. Not wrong, but not the one I'm looking for. You remember our people who had poor health literacy? A lot of those are going to kind of cross here. People with intellectual disabilities. You're going to have a hard time, much like children, determining, you know, where is your source of pain, what exactly is going on. So let's see what we missed. Infants and children, older adults, developmentally disabled, those with communication problems such as limited English, and those unable to communicate due to the illness or the treatment process. So patients who have tubes or they're, you know, lethargic, kind of in and out of it, you're going to have a hard time managing the pain for those patients. So this is easy for y'all. NSAIDs, the exact way that they work is not totally known. Good to know, huh? You're taking this stuff and we don't know how it works, but it works. They think that, remember we talked about prostaglandins yesterday and those effects that prostaglandins have on the body? They think that they work by inhibiting the action of the enzyme cyclooxygenase, which is responsible for prostaglandin synthesis. So they think that they work similarly to aspirin, but they are not totally sure on a molecular level. So NSAIDs inhibit two related enzymes. So it's that cyclooxygenase and the COX-2. So we know that these two have something to do with their mechanism of action, COX-1 and COX-2. So those are going to be, when you look in your book, there's a specific COX-2 and it's listed here, and it is Celebrex. So you need to remember that they know that's how Celebrex works, is a COX-2 inhibitor. And then, which has a lot to do with inflammation. All right. Ibuprofen and naproxen, they also block COX-2. They produce pain relief. They inhibit COX-1. They cause adverse reactions, including GI reactions such as stomach irritation and ulcers. So I want to go back. Okay, so we said COX-2 is Celebrex. Everybody's got that in their brain? Only one. The one that specifically acts on COX-2 is Celebrex. All of the other NSAIDs are somehow working with COX-1, maybe a little bit of COX-2. But did y'all see that one of the things that COX-1 does is maintains the stomach lining. So if we're blocking that enzyme, what is potentially happening to our stomach lining? It's deteriorating, it's at risk for ulcers, that mucus is decreased. So that being said, these NSAIDs, what can they, and y'all probably know this already, what are they bad for? The GI system. Stomach irritation and ulcers. Okay, so don't look at that bottom yet either. Based on some of the musculoskeletal disorders that we learned about, what do you think we're going to use NSAIDs for? So y'all, y'all should know at least 4 things that we're going to use NSAIDs for. Then help anybody. Come on. Draw a straw. I don't care if y'all don't know. Inflammation. Inflammation. Okay, give me a disease process that causes inflammation. Rheumatoid arthritis. What else? You're killing me. What'd you say?
I said a lot of autoimmune.
Yes, some autoimmune diseases can. Specifically musculoskeletal. What did we talk
Would
about?
it just be like injuries, like muscle strains and sprains?
Muscle strains and sprains, anything that causes inflammation. What else? There's one that I'm thinking about that we give specific medications for the uric acid. Gout. But they're not necessarily acting directly on that inflammation, so they're often going to be used in conjunction with other therapy. So we might say, take a Flexeril for your muscle strain, but also take this anti-inflammatory, this NSAID, for more of a pain relief. You know, pain plus inflammation, and then your Celebrex is working a different way. So oftentimes those medications are going to be used in conjunction with other medications. So they're used for osteo, rheumatoid, other musculoskeletal disorders, mild to moderate pain. You ever taken ibuprofen for a headache? Yeah. Primary dysmenorrhea. So everybody ever took them for period cramps? Yeah. Probably not, Brendan. Fever reduction. We've taken it for all of these things, right? So we know these drugs already. Examples of NSAIDs. Do y'all know any offhand? I told you one already. Ibuprofen.
Sorry.
Aleve. Celebrex is a what kind of inhibitor? COX-2. So y'all already know 3 of your drugs in this drug class, okay? Some of the commons. Diclofenac. Your profens. You see ibuprofen, phenaprofen, flubiprofen, all of those. Ketoprofen, y'all seeing some familiar stuff there. Mobic is a very common one. Meloxicam. That's usually, Mobic is a prescription drug. Naproxen, that's a lead. And that's about it. That's the ones I would want y'all to know. And do y'all see those NSAID combinations at the bottom? So look at those drugs. I'll be so proud if y'all know this. Look at the combinations and tell me if the second portion looks familiar, and if so, why are they given together? Prozols, what do prozols do? Yes, yes. And what do proton pump inhibitors do? Inhibit GERD. And what? And also protect the stomach lining, right? They don't necessarily put a coat, but they offer protection. And what do? Potentially deteriorate that. So we are being prophylactic, we are being preventative by giving those drugs in combination. Make sense? All right. All right, the next page. Well, not the next page. All right, adverse reactions. Nausea, vomiting, dyspepsia, diarrhea, constipation, epigastric pain, indigestion, abdominal discomfort, intestinal ulceration. What do those all have to do with? Your GI tract. So when y'all are memorizing your side effects, think GI. Make your life easier and think GI. Jaundice, bloating, anorexia, and dry mouth. So not nearly to the extent of Tylenol. Priority care is related to the stomach. NSAIDs in higher dosages are not great for your liver, but that's in high prolonged use, but not to the extent that Tylenol is. When you think liver, you need to think Tylenol. When you think NSAIDs, you need to think gut, okay? But know that it all kind of works together. All right, NSAIDs can cause anxiety, lightheadedness, headache, drowsiness, somnolence, insomnia, confusion, depression. Is that stuff common, you think, for NSAIDs? You know, not really. It's not of that utmost, not to say it's not possible. There are potential adverse reactions, but most people don't have CNS side effects as related to NSAIDs. And then you can have cardiovascular reactions as well. All of this, again, to say, even though most of them are over the counter, we need to know that our patients are taking them, right? And this just goes into all of the ways that they could affect each different body system. Hematuria, cystitis, I'll point out the biggies on these, but I need you to think stomach above all else. I'll narrow that down for you because it's a little much. But y'all do see that it could potentially affect any system of your body. So it is important to gather that information from your patients. All right. All right, remember we talked about cross sensitivity? We've talked about it specifically in regards to antibiotics, right? So NSAIDs, if you're allergic to one NSAID, you're usually allergic to other NSAIDs. So if you are allergic to ibuprofen, you're often allergic to phenaprofen and have a sensitivity to naproxen. You know, there's usually a cross sensitivity when you are allergic to one of them. All right.
Is that common?
What's that?
Like to be allergic to?
Not incredibly common. Like I don't see, more often than an allergy, you will see people list it as an allergy because they've had ulcerations in the past and they want to avoid it more so than an actual full-blown anaphylactic, you know, personal reaction. It's more of a, please put that on my chart because if I take it, you know, then I'll have a bleeding ulcer kind of thing.
But the ulcers aren't an allergic reaction.
No,
It's
the
kind of
ulcers-
like common, like is that something that we know it does?
So it's something we know it does, so it would be called an adverse reaction, and we would absolutely want to, that's why we don't want to take it on a prolonged basis,
Right.
and that's why we want to have them report, you know, if every time you're taking your meloxicam, you have this horrible burning in your stomach, we want to be aware of that before it eats a hole and you have blood in your stool, or, you know what I'm saying, or you're vomiting blood. So it's not an allergic reaction, it's an adverse reaction. So let's see. If someone has a hypersensitivity to aspirin, they sometimes will also have a hypersensitivity to NSAIDs. Think about the prostaglandin stuff. Even though they don't know exactly, they know enough to know that they're pretty sure it has something to do with that. So that makes sense. And then Celebrex, people who are allergic to sulfonamides or have had a history of cardiac disease or stroke are not given this COX-2 NSAID. We use them cautiously in pregnant people, renal disease, cardiovascular disease, liver disease, and elderly people. Okay, so that is pretty much, the rest is going to be teaching and drugs that we're not going to give together. So without looking at this, drugs that we've already learned about that y'all think we would not give NSAIDs to. Two different, one we learned about yesterday and one we learned about a couple weeks ago. Aspirin and NSAIDs. And we're not given NSAIDs with, yeah, I know that. I know y'all do. I do. We're not, but I'm looking specifically in regards to bleeding, but correct. Yes. Yes. Warfarin. Contraindicated with anticoagulant use because it's increasing their risk of bleeding. Lithium. Remember I don't know if I told y'all because we haven't fully learned about lithium. Lithium has a chance for Stevens-Johnson syndrome. Lithium is used for seizures. It's also used for bipolar disorder and has a lot of drug-drug interactions. Just like, what's two other things that have a whole lot of drug-drug interactions? MAOIs. We're on it today. They're girl. What else? There's one more. Yes, the theophylline. Those are your big drug-drug interactions. Lithium is one of those as well. And so are hydantoins, which we just learned about. All right. So NSAIDs can decrease the effectiveness of antihypertensive drugs. And don't worry about the acetaminophen. All right. That is it for NSAIDs. That's it. We feel good about NSAIDs? I think y'all are going to do really good on this test. Okay.
I have a question. So it says that some are not used to treat the rheumatoid arthritis or osteoarthritis. Is it just because they work differently?
What does it say specifically?
It's the ketoloric methylphenidate and that methylphenidate. Some it says.
I don't actually know the rationale behind that. Ketorolac is often used post-surgical. That's a big post-surgery drug. And meloxicam is usually used for osteosis. They are
It says not rheumatoid or osteoarthritis.
used for osteo a lot. So I'm not totally sure the reasoning behind that. All right. The next thing we're going to talk about are migraine preparations. All right. So these medications, if you look, the ones that we're discussing primarily, what did they end in? Triptan. Triptan, triptan, however you want to say it. They end in triptan. They are serotonin 5-HT receptor agonists. So they are pain associated with migraine headaches is believed to be caused by vascular spasms. So me and my husband, we kind of go round and round about this sometimes. I haven't had a real migraine in a long time, but I used to get them, and I used to like puke my guts up and be totally miserable and yada, yada, yada. Well, every time he gets a headache, he's like, oh, I got a migraine. I'm like, bro, you don't have a migraine, you have a headache. Stop. And he's like, you don't know, and he's good in like, he takes some ibuprofen and he's good in like 30 minutes, okay? Migraines are different. They're usually associated, and people handle pain different. Again, it's subjective, but every headache is not a migraine, okay? So if they're believed, there's a whole bunch of different migraines, and we are not learning about that, but they're believed to be caused by vascular spasms. That is the thought process. That's what they think causes them. So drugs that are used to treat migraine headaches are given prophylactically, or they can be given for acute pain. So we can take them to prevent the migraines, or we can take them once a migraine occurs. So the symptoms of migraines are believed to be caused by local cranial vasodilation and stimulation of the trigeminal nerves. It's a spasm, but then it dilates. You know, like it spasms and then it dilates. So activation of the 5-HT receptors causes vasoconstriction, which decreases the pain. So the mechanism of action is to stop that dilation and constrict the vessel a little bit. They work multiple ways. They're used for relief of moderate to severe pain and inflammation related to the migraine headaches. Okay, so when I think of vasodilation, vasoconstriction, what is the first thing that you think about? Pressure, specifically like the circulatory system, the heart, right? So these medications, they can cause potential cardiovascular side effects, which makes sense if you think about their mechanism of action. And then they also cause some of those CNS side effects: fatigue, dizziness, nausea, flushing, all that stuff in your head, dry mouth, all that stuff. They're contraindicated in patients who are known to be hypersensitive to serotonin agonists. They should not be used in patients with ischemic heart disease, TIAs, uncontrolled hypertension, or those taking MAOIs. And they're used cautiously in patients with hepatic and renal function. So if we think about the if we think about the mechanism of action on how they work, the people that they're contraindicated in makes perfect sense, right? If we're specifically working on constricting those vessels. Okay. So we're going to, I feel like y'all are a little bit checked out. That's all the information. We're going to do like a little role play kind of question thing. All right. Where y'all are y'all kind of by your groups? Not really. All right. Y'all on trade desk now. Y'all know who y'all's people are. All right. You can buzz in. Tell me one thing that you are going to assess in a patient who is prescribed a NSAID. One thing you're gonna say. Inflammation. Okay, so what is their source of inflammation? All right, if I say, oh, my knee hurts so bad, what else are you asking me?
How does it hurt?
Yeah.
Like, is it radiating?
Yes, it radiates all the way down to my foot. What else are you asking me? Yes, you are. And what else are you asking me? Is that what you're going to say? Okay, so how bad does it hurt? Where does it hurt? Okay, so what if I say, oh my God, my head hurts. My head hurts. What are you asking me? Where does it hurt? What else are you asking me?
What does it feel like?
What does it feel like? What else are you asking me?
Scale of 1 to 10.
On a scale of 1 to 10, what else are you asking me?
If you feel dizzy.
Specific. What?
If you feel dizzy.
Do you feel dizzy? What else?
Like stabbing.
Descriptors of the pain. One other thing I'm looking for. How long? One other thing even after that.
Frequency.
Frequency. One more. Y'all doing great. There's one more.
Triggers.
Triggers. Okay, so with migraines, the reason that I wanted you to bring that out, with migraines specifically, there's often going to be an aura or a trigger. You know, something will flashing lights or really loud noises, or some people have migraines when they're on their cycle, different things like that. So if we can assess and get all the information that we need, then we can much better, you know, see if they're taking the right medication. What is the only COX-2 inhibitor that I want y'all to memorize? Celebrex. What is the generic name? Celebrex is the brand name. What's the other name? Yes. What does it work on? What is its mechanism of action?
Inhibits COX-2.
Inhibits COX-2, which also, okay, so all of the other NSAIDs are going to also inhibit COX-1. What is another function of COX-1 outside of inflammation?
Maintains the stomach
Maintains the stomach lining. So everybody that's on an NSAID, what are we, back to the original question that I asked Brendan, or he said inflammation, once we implement treatment, once we've assessed and implemented and they're taking these drugs, what are we continuously reevaluating? Their GI tract. We feel very good about this, yes? Yes. All right. So,
Could it cause them to throw up?
it could cause them to throw up. Good. Now, any GI issues?
Yeah, well, I don't know if it was like just going down or just come up.
Yeah, any GI stuff. We want to know specifically about their cardiovascular history, especially in regards to migraine preparations. Arthritis, is it a soft tissue inflammation or is it something like gout? Their ability to carry out activities of daily living, I'll said all this already. Pain relief, how oral medication, when are we going to reassess their pain? 30 minutes. Up to an hour, but at least at that 30-minute interval.
I just have a question.
Yes.
So like I have a history of stomach ulcers. I do have really high acid levels, so I take acid reducers. So I take ibuprofen all the time. So is that not good for me?
So that's one of those things, you're taking those acid reducers and you are, so I would say all the time. What do you consider all the time?
Like I take it once a day.
Once a day, you take it every day? Something to monitor.
Yeah.
You know, if you're not having any additional issues, but Tylenol would usually be a better option for somebody who has
I just didn't even know that.
has known GI stuff. And once a day is not, you're not taking it 3 times a day. and you're on something to already help with your acid, with your potential, sorry, say the word for me.
Potential.
Thank you. Your potential for developing those ulcers, but definitely something to keep in mind for sure. If our patient has liver damage as related to NSAID use or non-salicylate use, what would you look for in those patients? Jaundice, yes. Very good. And there was another question I was going to ask you. If they had renal issues as related to any of these drugs, what would you assess there? Not necessarily you're thinking in the right direction, but they don't necessarily cause infection. It has to do with urine, but not necessarily infection.
Their output and like
Their
their color.
Specifically output and BUN and creatinine, specifically for renal function, okay? All right, that's it. Let me make sure we went through all this. They can have acute pain, chronic pain, impaired physical mobility, risk for injury, risk for impaired skin integrity. At the end of the day, we want them to have an optimal response to their drug. If not, we're going back to the drawing board, right? Okay, this is important to know. In teaching these patients, NSAIDs should be administered with food, promoting NSAIDs administered with food or milk. We don't want to take them on an empty stomach because we know that our stomach is already at risk for, being compromised. So with food or milk or with some antacids, like you said, you already take an antacid. For NSAIDs, not all NSAIDs, but the inflammatory process is not something that is immediately reversed. So a lot of NSAIDs take a week, 2 weeks, 3 weeks, especially, in addition to our gout medications. If we're taking them for a source of inflammation that is recurrent, then it's going to take 2 to 3 weeks for them to really get their full effectiveness. So if they take, yes, we get some relief like from a headache when we take them, but that is more its analgesic effect. Does that make sense? That's not necessarily its anti-inflammatory effect. So sometimes these drugs take a little bit longer to reach their full therapeutic response. All right, we know elderly people are more at risk for GI bleed. And then we wanted to take it with a full glass of water and food. We want to provide comfort measures, and we want to promote non-pharmacologic stuff too, like ice, heat. We don't want to just start saying like you should do this, but whatever is in your scope and your physician has told you, like to educate on this, and you work at a bone and joint clinic, you can absolutely provide that information to them if you are knowledgeable. And we want to assess their need for crutches, walkers, canes, observe for drug interactions. And then we said that NSAIDs could potentially, look at the chart on page, it's a big chart, I just gotta find it. Maybe it's not. Did y'all see a chart with all the body systems that it can? Okay, yeah, look, it's on a chart. See under adverse reactions, and it goes under each, the way this PowerPoint did, it can affect the GI system primarily, the central nervous system, cardiovascular, you see all those whatever, so know that it potentially can have an effect on all of these body systems. So you need to know that it has a very wide range of adverse reactions. Does that make them common? Not necessarily, but it doesn't make them less real. The fact that, so if someone says, every time that I take ibuprofen, my vision gets really blurry, they're not totally crazy. you know, because it could potentially have side effects on, you know, CNS side effects. So making sure that in regards to whatever their complaint is, you're teaching in that direction. So if they are having blurred vision, what are we concerned about?
Safety.
Safety. Okay? If they are having, let me think of another one. If they are having skin issues, they're having atopic dermatitis related to their NSAID use, and they're scratching and scratching and scratching, and they have open sores on their arm. What are we assessing and what are we concerned about? Risk for infection. So that's how I need y'all to think in regards to these side effects. What, these adverse reactions, what is your priority? If I say, so yes, stomach is priority always in regards to NSAIDs, but if I specifically say it's causing pruritus, the patient is itching all night long, blah, 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 we are now concerned about infection. Yes? All right. Ding, ding, ding. We're for real done with that now? All right. You want a minute?